Hi everyone, welcome to our module on spinal disorders and back pain. So this is the seventh video of our musculoskeletal system series, and we'll be ending it in the with the next video on metabolic bone disorders. Before beginning with the video, I'd like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everybody. If you find it useful and wish to support its continued development, voluntary contributions are welcome. You can pay with the link that is on the screen, and that's also pinned in the description, and you can pay with any of these payment methods. Now we move to spinal disorders, which are one of the most common causes of back pain and neurological symptoms. Several major spinal conditions that are frequently tested in exams includes intervertebral disc herniation, degenerative spine disease, spinal stenosis, spondylolysis, and spondylolisthesis, and finally spinal cord compression. These disorders may be present with symptoms like back pain, which is localized, then radiating pain along a nerve root, muscle weakness, or sensory loss. In exam questions, the key strategy is to recognize the pattern of pain and neurological deficit and then connect it to the most likely spinal pathology. To understand spinal disorders, it is important to review the basic anatomy of the vertebral column. So we'll do that first. The vertebral column is composed of 33 vertebrae. These are divided into 7 cervical, 12 thoracic, 5 lumbar vertebrae, and 5 fused sacral vertebrae, and 4 fused coccygeal vertebrae. The vertebral column serves several important functions. It protects the spinal cord, supports body weight, and allows flexibility and movement of the trunk. Between adjacent vertebra lie the intervertebral discs, which act as shock absorbers and allow controlled movement of the spine. Each intervertebral disc has two main components. The outer layer is the annulus fibrosus, which is a strong fibrous ring that provides structural stability, whereas the central component is the nucleus pulposus, which is a gel-like structure uh, and forms the central core, which provides cushioning and flexibility. With aging or mechanical stress, the annulus fibrosus may weaken or rupture. So when this happens, the nucleus pulposus might protrude outwards. This process leads to disc herniation and can compress nearby spinal nerve roots. Disc herniation occurs when the nucleus pulposus pushes through a weakened annulus fibrosus. Several factors can contribute to this process. The most common is age-related degeneration of the intervertebral disc. Other causes includes heavy weightlifting and sudden spinal flexion or repetitive mechanical stress on the spine. The most commonly affected levels in the lumbar spine are L4, L5, and L5S1 because these segments experience the greatest mechanical load. When a disc herniates, it might compress the adjacent spinal nerve roots. This compression produces symptoms such as radicular pain, numbness, tingling, or muscle weakness. One classic example is sciatica. So, in sciatica, pain begins in the lower back. After beginning in the lower back, it then radiates down the leg along the course or path of the sciatic nerve. In questions, so whenever there's combination of lower back pain with radiating leg pain, so it could strongly suggest lumbar disc herniation. Radiculopathy refers to dysfunction of a spinal nerve root. This usually occurs when the nerve root becomes compressed or irritated. The most common cause is herniated intervertebral disc, but other causes includes the degenerative spinal disease, spinal stenosis, tumors, and infections. Symptoms might vary depending on which nerve root is affected, but they often include radiating pain, numbness, weakness, and change in reflexes. Difficult lumbar nerve roots produce different kinds of characteristic symptoms or findings. So, the compression of the L4 nerve root often causes weakness in knee extension and reduced patellar reflex, whereas compression of the L5 nerve root leads to weakness of foot dorsiflexion, and weakness of foot dorsiflexion would eventually make it difficult for the patient to walk on their heels. Compression of the S1 nerve root produces weakness of plantar flexion and reduced Achilles reflex. Recognizing these patterns like L4, weak knee extension, reduced patellar reflex. L5, weak foot dorsiflexion, difficulty walking on heels. S1 nerve root, weak plantar flexion, and reduced Achilles reflex. So, recognizing those patterns helps us localize the level of nerve root compression. Now, moving on to sciatica. Sciatica refers to pain that radiates along the distribution of the sciatic nerve. This condition is most commonly caused by lumbar disc herniation. Patients typically experience low back pain that radiates down the posterior aspect of the leg. The most commonly involved nerve roots are L5 and S1. Sciatica is a very common clinical presentation of lumbar radiculopathy. The straight leg raise test is commonly used to evaluate lumbar disc herniation. So whenever we suspect lumbar disc herniation, we can perform this straight leg raise test. So during this test, the patient lies flat while the examiner lifts the patient's leg with the knee extended. So the patient experiences pain radiating down the leg when the leg is raised between 30 and 70 degrees of angle. The test is considered positive. So this indicates irritation or compression of a lumbar nerve root. So whenever pain is present or when there's uh, elevation at level of 30 to 70 degrees, so this might suggest nerve root compression, usually after a disc herniation. The crossed straight leg test is another diagnostic maneuver that is used in evaluating disc herniation. In this test, the examiner raises the unaffected leg. So if this movement produces pain in the affected leg, so then this test is considered positive. This test is more specific for lumbar disc herniation and it might strongly suggest nerve root compression. Degenerative disease occurs due to a gradual wear and tear of the intervertebral discs. So, as people age, what happens is these intervertebral discs lose water content and elasticity. So, this loss of water content and elasticity would eventually lead to reduced disc height and a weakening of the annulus fibrosus. So, all these changes at the end of the day, they decrease the ability of the discs to absorb shock and can contribute to chronic back pain. Spinal stenosis refers to narrowing of the spinal canal. So this narrowing can compress the spinal cord or nerve roots. So common causes would include degenerative disc disease, osteophyte formation, and thickening of the spinal ligaments. So in spinal stenosis, patients might experience back pain, numbness, and weakness in the lungs, and this pain often relieves with uh, bending or leaning forwards. A classic symptom of lumbar spinal stenosis is neurological or neurogenic claudication. So patients experience leg pain, numbness, and weakness while walking. So the symptoms improve when the patient sits or just when the patient just tries to bend forwards or flexes the spinal cord. This occurs because flexion of the spine increases the space in the spinal canal, and when there's increase in the space in the spinal canal, there's uh, a relieving factor. That's a relieving factor of the spinal stenosis, and that helps relieves the nerve compression. Spondylolysis refers to degenerative changes in the vertebral column. So these changes includes disc degeneration, osteophyte formation, and thickening of spinal ligaments. So these structural changes can compress the nerve roots or the spinal cord and can lead to neurological symptoms. Cervical spondylosis refers to degenerative changes in the cervical spine. So patients might present with neck pain, arm pain, or numbness in the upper limbs. In severe cases, cervical spondylosis can cause cervical myelopathy. This condition can lead to difficulty walking, poor coordination or loss of coordination, and upper motor neuron signs. Spondylolysis refers to a defect or fracture in the pars interarticularis of a vertebra. So the interarticularis is nothing but a region between the superior and the inferior articular processes of a vertebral body. So just imagine a vertebral body that vertebral body has superior and inferior articular process on the posterior side. So this is called as a pars interarticularis. So spondylolysis refers to a defect or fracture in this particular part called as a pars interarticularis of a vertebrae. So uh, this condition commonly occurs in athletes who perform a repetitive spinal extension. So repetitively just performing spinal extension, what happens is there might be a fracture of the pars interarticularis because that's a kind of a stress fracture occurring at the level of the vertebra. So when the vertebra becomes unstable, it might slip forwards over the other vertebra below it. So when such slipping happens, it is called as spondylolisthesis. So the commonly affected vertebra in spondylosis is nothing but fracture of the pars interarticularis. So the commonly affected vertebra is L5. This is often seen in athletes, gymnasts, and weightlifters. So repeated spinal stress can cause stress fractures in the pars interarticularis. So this can lead to structural weakness of the vertebra, reduce its spinal stability, and it can present with features like lower back pain, pain worsened by spinal extension. So some patients might remain asymptomatic, but the classic feature is a lower back pain, and the pain is worsened with spinal extension. Diagnosis is often made through imaging studies where we just observe the lateral view of the spinal cord. The spondylolisthesis occurs when one vertebrae slips forward over the other vertebrae below it. It most commonly occurs at the level of L5S1 vertebrae. So it develops as a complication of spondylosis. So whenever there's a fracture of the pars interarticularis, there is just loss of the binding force. There's just a loss of the adherence of one vertebrae to the other. And what eventually happens is that whenever there's a flexion or extension happening, what happens is that the vertebrae that's above that's actually fractured, it slips over the vertebrae below it. So this is probably uh, possible at L5S1 level. So types of spondylolisthesis includes ischemic due to Barr's defect and degenerative due to age-related changes. On imaging, the classic finding is Scotty dog sign on oblique lumbar X-ray. So this is called as the Scotty dog sign. So just we can just observe the image where we would be able to observe a dog-shaped hyperlucency on an oblique X-ray of the spinal cord, and I'm pointing towards the pars interarticularis. So we can just observe that there's a characteristic fracture which just leads to slipping of the one vertebrae over the other that's below it. Clinical features of spondylolisthesis includes lower back pain, hamstring tightness, radicular leg pain. Severe vertebral slippage may cause compression of the nerve roots, which causes numbness, weakness, and sciatica like symptoms. So, in advanced cases, spinal instability may occur. So, imaging is used to confirm the diagnosis. So, common findings that are includes the pars defect on an X-ray or a CT scan, and vertebral slippage is visible on lateral spine X-ray. So we can clearly observe a vertebral slippage at this particular point. So the classic sign that is seen in spondylolisthesis is a Scotty dog sign on oblique lumbar X-ray. So a fracture in the neck of the Scotty dog indicates spondylolysis. Most cases of back pain are benign and malignant. However, certain symptoms suggest serious underlying diseases. So these red flags includes severe neurological deficits, bowel or bladder dysfunction, history of cancer, fever, infection, or unexplained weight loss. So with these features are present, whenever these features of neurological deficits, loss of bowel and bladder control, history of cancer, fever, infection, and unexplained weight loss. When these features are present, urgent evaluation is necessary. So these findings may indicate spinal infection, tumor, or Cauda equina syndrome. So immediate evaluation is an emergency requirement. Cauda equina syndrome occurs when the nerve roots at the lower end of the spinal cord becomes compressed because of spinal stenosis. The most common causes includes lumbar disc herniation, spinal tumors, or trauma. So classic symptoms includes severe low back pain, saddle anesthesia, urinary retention, urinary incontinence, and weakness in the lower limbs. So this condition is a neurosurgical emergency because permanent neurological damage may occur if the treatment is delayed. So this cauda equina syndrome could lead to permanent neurological damage. So it should be dealt as a neurosurgical emergency. Spinal cord compression occurs when the external pressure damages the spinal cord. The common causes include tumors, vertebral fractures, and epidural abscess. Other symptoms might include back pain, weakness in the limbs, sensory loss, and difficulty walking. So, early diagnosis and treatment are essential to prevent permanent neurological damage. So, back pain can be divided into mechanical back pain and inflammatory back pain. So, mechanical back pain typically worsens with activity and it improves with rest, whereas inflammatory back pain is worse in the morning and it improves with movement. So, inflammatory back pain is commonly seen in conditions such as ankylosing spondylitis. To summarize the key exam patterns, we'll just recall everything. So, back pain with radiating leg pain might suggest disc herniation, whereas pain while walking that improves with the bending forwards might suggest spinal stenosis. An athlete with lumbar pain and pars defect might suggest spondylolysis. Forward vertebral slippage suggests spondylolisthesis. Finally, saddle anesthesia with bladder dysfunction suggests Cauda equina syndrome. So, recognizing these patterns will definitely help us rapidly diagnose all the conditions whenever you're solving questions. So, in the next video, we'll be studying about metabolic bone disorders, and that will be end of this musculoskeletal system series on USMLE with one. Uh, just subscribe and keep waiting for many upcoming lecture series. See you soon. Bye.